Hi folks, good evening. You're very welcome to the last in our series of this SIG series on death, dying and bereavement. Anybody here for the first time tonight? Oh, particular welcome to you. It's nice to see the repeat customers as well, but you're very welcome if it's your first as well. Just a couple of housekeeping things. I'm Susan Delaney. I'm the chair of the SIG. We will give you tonight, if you don't mind, some evaluations, just that will help us to have an idea of how it was for people, what was useful, or going forward what we might be providing for you. So really would appreciate if you fill them out. They're anonymous, feel free, put what you like on it, and we'll collate them and put a bit of feedback around on them. But we'll try to take on board your suggestions and criticisms. Hello, Mary Marcy. I suppose my sense is any kind of particular training for psychology should go through the SIG, and we'll try and attend it. As a bit of an infomercial, I did bring you some information from the Hospice Foundation where I work, because we do obviously a lot of training in bereavement, and you're welcome, you can help yourself to that. We have everything from the 1-hour trainings up to the masters, and I also left some cards if you wanted to be on our mailing list to know about upcoming trainings. We'd be happy to do that for you. That's not specific to psychologists, obviously. It's just professional audience usually. And I also left some information on our library if you're interested in using it or joining it, just as information. What I'm very excited about tonight, though, is to say we have Dr. Paul Dalton here from Psycho-Oncology in St. Vincent's Hospital, with an intriguing title, I think, Lost and Found: The Ancient Wisdom of Self-Compassion for the Contemporary Psychologist. And I think if we'd had things totally our way, we might have perhaps started with this talk, because I think the self-care is where everything starts. I haven't heard Paul presenting on this, so I'm looking forward to it. I don't know what to expect, but I do know Paul, and I expect it to be thoughtful, reflective and interesting. And I'm happy to hand over to Paul. Paul, I would add, is the chair of the SIG, and this was his idea. I got to say, I wondered, would we be talking to ourselves here on the Tuesday evenings? But it was a good idea, and all thanks to Paul for that. Thanks, Paul.
Thanks, Susan. Thanks very much. So, thanks very much, Susan. Nice to see lots of familiar faces. So I'm not sure if tonight would be better to kind of for me to talk a little bit and have a bit of a conversation as we go, or for me to talk and then we might have that conversation at the end. I think in the last few weeks there hasn't been too much chat, which is unusual. So will we just kind of see how it goes? I'm happy to do either. So if there is a particular point that you're interested in or not sure about or think is rubbish, let's just stop and talk through that then. I'd be very happy to if we worked that way. This is a photograph of well, you can see two dogs. On my way to work, there's a little bakery, and I stopped one morning, and they're there, and this one rests on the back of the other one several mornings a week. So we are going to talk. I'm going to talk about self-compassion and the wisdom, perhaps, of self-compassion, and more specifically, looking very broadly at mindfulness, and the idea, the concept that when we get into the area of mindfulness and of self-compassion in particular, invariably we get lost, but invariably we get found too. We get lost and we get found. When we talked about me talking about mindfulness, I have to say the more I know about mindfulness and the more I speak at things like this, the more uncomfortable I get about talking about mindfulness. I'm really I'm uncomfortable about it, and I'm sometimes quite reluctant to talk too much about mindfulness. Having trained as a psychologist, as a clinical psychologist, we, as you know, aspire to an evidence base for our intervention. That's just as important when it comes to the application of mindfulness as a clinical intervention. I did my first training in mindfulness in Oxford in the Centre for Cognitive Therapy about 10 years ago, and then was lucky enough on a couple of occasions to do further training in the University of Massachusetts, where John Kabat-Zinn began mindfulness, if you like, as a clinical intervention in the 1970s. So I was there a couple of times, which was a wonderful opportunity. I work in St. Vincent's in psycho-oncology, and we've trained a little over 200 patients in the 8-week program over the last number of years. So it has a bit of a culture, I suppose, and kind of recognition there. They've mainly been oncology patients, outpatients. We've done some training with staff over the years as well. But as I say, I'm always cautious about mindfulness, and I'm very cautious about the broad kind of popularity that mindfulness has, that it's gained in the last number of years. I think there's two reasons for mindfulness being very popular. I think mindfulness makes sense. It has a validity. It has an immediate, intuitive kind of appeal. And I think also mindfulness has a kind of a romantic, kind of seductive quality to it. A kind of that sounds a nice way to avoid myself or the worries of the world or all of that. There's something potentially, I think, quite appealing to it. I think particularly there's something appealing about mindfulness, given the culture, the world that we live in, the frantic pace at which we live. On several occasions, I've been on my way to teach a mindfulness class in the hospital and been stopped by one of the nurses or doctors. They say, "Well, it's kind of 6 o'clock. Or what do you do?" And I'd say, "Oh, I'm going to teach the mindfulness stress reduction." And invariably, they say, "Oh, I could do with that." Right? That there's a kind of I know that I know that might make sense to my life. When I did the first training in mindfulness, I was working in adult mental health service, and I remember kind of coming back full of zeal and thinking, "Oh, this is the answer." And over the years, I've learned that that's not true at all. As healthcare professionals, as psychologists, we need to exercise caution about any intervention. And constantly seek evidence before application. Mindfulness is not the panacea to all psychological suffering or pain. I think there's something about, if I haven't said this already, there's something about the science, what we do, our profession and other professions. There's something about science catching up with the popularity. So this has become a popular way to intervene, but science is catching up with that, and we don't have the evidence base yet. So we need to know that. Today I want to have a little look at mindfulness. I want to look at its origin and some of the research that supports its clinical efficacy, and in particular I want to have a look at self-compassion. Self-compassion is a relatively new construct for Western psychology, and it's even newer when it comes to being a clinical intervention. So only in the last couple of years have we seen the introduction of formal self-compassion trainings, which I'll talk a little bit about. Does that sound reasonable enough for? Yeah. I was talking to a patient about a fortnight ago, an elderly lady on the ward, probably with a non-curative cancer, probably with a few weeks to live, a very contented woman who certainly didn't need to be seeing a psychologist in her late 80s. And I said to her, I said, Rose, when you look back at your life, is there anything that you regret? And she smiled and she kind of looked out the window and she said, I wish I hadn't worried as much. She's 88. She said, I wish I hadn't worried as much. So I was quite struck by that. And I think maybe, like me, you may have experienced the kind of nighttime soap opera of the mind, when the mind develops a mind of its own. I can't remember who referred to it as the tired but wired phenomenon. So we find ourselves physically very tired, but psychologically, emotionally, cognitively very wired. Often we get ourselves into situations where we try to solve problems in an attempt to get to sleep or to switch off the racing mind, but that doesn't work. And often we find ourselves beginning the next day perhaps tired, a little irritable, not in great shape. And again, I think some of you may recognize the days that are dominated by the to-do list, the next thing and the next thing and the next thing. Often with a kind of an underlying kind of contract that we make with ourselves that says kind of, once I have this done, I'll be happy or calm or more at peace or gentle. Only to find that we very quickly move on to the next to do. We are increasingly turning into humans doing as opposed to humans being. And some of that doing we'll talk about a little bit later, is often around our attempt to manage worry. I don't think she'd mind me saying this, but I grew up with my mother, who we shared a house, and she had this kind of idea, not verbalized, but she had this kind of idea that she could only relax when the laundry basket was empty, and then when it was, she'd start to worry because it was going to rain and everything was going to get wet in the washing line, and so it went and goes in a cycle like that. I think sometimes our human restlessness or our underlying dis-ease, our very scared selves often propel us into doing more and more and more. We, I think, live with the promise of being relaxed at some point in the future. The Friday night glass of wine, the Sunday brunch, the 2 weeks in the sun, the getting that report written, that degree finished, that, the last patient of the day. Living with that kind of idea or frame that one day or at some point I'll be relaxed or calm or together. Often finding that when we get there, so at the end of the week, the last patient, the final degree or whatever it is, that our underlying dis-ease just won't go away. It simply gets transferred onto another concern. Over the years, and you guys people will know more about this than I do, but over the years, various philosophers and more recently psychologists have offered various attempts to explain that human state of dis-ease, or this human predicament of always feeling restless and compelled to do the next thing. So lots of people have offered opinion and theory and models for that. I'm a psychologist, so I'm going to talk a little bit about the stress literature, because I think what some of the stress literature research and models have to say offers a reasonable explanation, to my mind, to help us understand that propensity to keep moving, that propensity perhaps to worry too much. As you know, the beginning, the stress models and theories began with the work of Cannon in 1932, and he brought to us the flight or fight model. And in that model, just to recap or to remind people a little bit, is he emphasised the really important and central role of the very primeval part of the brain called the amygdala. The amygdala. The amygdala, as people know, is the most ancient part and primitive part of the brain structure. And in the amygdala, as you know, it houses the rapid response system. So it houses that piece that makes us react very quickly or very automatically in a situation where there's danger. So it happens here. The system, it's this system that automatically, in the amygdala, that automatically kicks in when you're standing at the side of the road at a pedestrian crossing and a child walks out in front of a car. It's that gets you into action. Or indeed, if you're driving the car, to put your foot in the brake. So, it's terribly important. However, as you know, the amygdala is not the most sophisticated part of the brain. Apparently, we're looking at about 150 million years of evolution that has the amygdala where it is right now. So it's been a long time evolving, but it's not very complex. As I say, it's not sophisticated, and it tends to make very rapid and unelaborated and rather simplistic interpretations of danger. Right? So it doesn't, not the most sophisticated. Importantly, the theory would say that the amygdala makes no distinction between the real and the imagined sense of danger. Right? So it makes no distinction, apparently, between the tiger, the snake, the fast car, or the imagined danger. So the internal imaginings worry. So what I create in my mind, it's not good at distinguishing the real from the imaginary. So when the real or imagined danger is sensed, the amygdala kicks the body into a hyper arousal. And you know this, right? But just to recap. And when the body is kicked into a state of hyper arousal, eventually there's lots of adrenaline going through the body. And with that, our pupils dilate, so we can see better. Our hair stands on end, so we can sense danger, threat, movement in the forest, movement. Our heart rate increases by 4 times, so that blood can be delivered to the large muscle groups, so that we can fight or flight, so we can get into a scrap or we can run away. The body is preparing for your survival. You know our shoulders, these symptoms that we experience. So our shoulders come up to our ears. Why does that happen? So we look a bit bigger. We begin to sweat. Here he would suggest that we begin to sweat, so that when I'm grabbed, I can slip away. We begin the butterflies. So think of going into an interview or kind of first date or last date, and the butterfly that goes on, the butterflies that go on there, and essentially it would appear that's the blood flow being redirected from where it's not needed. Because it's not needed there to help digest your food at that point in time. It's needed to get to the larger muscle groups so you can get out of there or you can fight. So our bodies, when they kick into action, when they kick into the rapid response controlled by this, that's what happens. That state of high alert is really important, because if we didn't have it, we wouldn't have made it here today. If our ancestors didn't have it, they wouldn't have survived. So it's terribly important to our survival. So the idea, that our stress response is really important to promote and provide for our survival. As you know, one of the problems with the amygdala is its inability to distinguish between the actual and the imagined. So, as I say, the snake, the car, or the feared outcome, or the memory, the internal. And as a result, often what happens is that the amygdala, when there isn't an external threat, but there is an internal threat, an imagined internal threat, the amygdala gets left on. Okay, so it's on. It's on all the time. It's I've said this before. It's a little bit like, the Des Bishop does a sketch about the Irish mother's obsession. Thanks, Neve. The Irish mother's obsession with the immersion. He's a very funny thing, right? So that's a little bit like, turn it off, what's been on 24/7, turn off the immersion. The problem with the amygdala, because of the imagined piece, is that it gets switched on and it gets left on, like the immersion, it gets left on, not what it was made for. As you know, very few of us here are under physical threat right now, or probably for most of today, or most of maybe the last number of years. Our physical survival isn't under threat. I think it's not too much of a jump to say, and there's maybe a little bit of literature and research to support this, that we're no longer under physical threat as human beings most of the times in our lives. But what we are under is our psychological threat. Our psychological survival is under threat in the world we live in. And that's, I think, as simple as, am I lovable? Am I good enough? Will I be recognized? Will I be remembered? Will I be ashamed? And I think it probably accounts for some of my own kind of mild level of anxiety at the moment is probably, theoretically, about my survival. So important that I survive here psychologically in front of my colleagues and peers. It's unlikely I'm going to have a heart attack, but it's important to me that kind of people walk out of there thinking, he's not stupid, at least. Do you know what I mean? Give me that much. So our psychological survival is key. How I'm seen, how I'm remembered, how I'm loved, how I'm regarded at a very, very deep level, how I'm regarded, and I think that can cross a professional and personal boundary. I think it's probably a lot to do with, and the literature in terms of social anxiety, and specifically in terms of public speaking anxiety. Some of the guys from the Oxford CBT school, Gilbert and the like, talk, I think, very sensibly about what happens to some of this kind of behaviour when in public speaking or in social situations. the anxiety that we may even feel at times of socially, maybe coming to an event like this, that mild kind of anxiety. One of the further added difficulties with the amygdala is what we continue to create in our mind. So when your loved one doesn't come home at midnight, when your teenager doesn't text for 3 hours, you don't really are, right? We invent all sorts of scenarios, all sorts of stories, all sorts of and probably, depending on your style, will have maybe strong kind of images of what's happening, the feared outcome, or very powerful thoughts about that. And those images, the imagined, are essentially what keep the alert, the high alert button, on. The difficulty with this is that it is exhausting, emotionally, psychologically, spiritually. So the high alert button, the immersion, was not meant to be on 24/7, not made for that. And when it gets out of control, we become exhausted, psychologically and emotionally, and indeed, I think it's fair enough to say, can lead to the presentation of clinical anxiety and depression. I was with a patient a couple of weeks ago, lovely man, and in his early 40s, with again a terminal diagnosis of cancer. He had I'd known him for several years, and he was married with a couple of children, several children, beautiful children. And he said to me a few weeks ago, he said, Paul, the really hard thing about me dying is that I had a really good life, but I wasn't there for it. We talked a little bit about what that might actually, what does that mean? Being there or not for one's life. The problem, I think, and not to build too much on it, but the problem with being on high alert or being in a state of perpetual kind of worry and distraction is that we invariably miss the most important and beautiful points in our own lives. If our minds are preoccupied and concerned about the future, so the feared outcome, if our minds are preoccupied with the past, the regret, what didn't happen, we end up missing, I think, the most beautiful parts of our lives. We end up living a life, but not being there for it. There's a story told, and I've heard it from a few sources, so it must be true, about a group of scientists, a lot of kind of neuropsychologists and psychiatrists and the like, and they were at a conference in India back in the early 90s, and the Dalai Lama gave the keynote. People may have heard the story already. Dalai Lama gave the keynote address, and then there was some time afterwards for Q&A. And there was various questions. And one of the attendees asked the Dalai Lama, she said, Sharon Salzberg, she's written about it, and she said, Dalai Lama, she said, how do you understand, or how do you feel, what do you think about self-hatred? And because of the silence, and he kind of looked at her like she said something really rude. And she said, how do you feel about self-hatred? And he's a couple of interpreters, and he asked one of them, and then he asked someone else. And he could not understand the concept. And he said himself, he wrote a few years after it, saying that up to that point he thought that he had a very keen understanding of the mind, but he never, he could not understand the concept of self-hatred. I think one of the important distinctions, I think, perhaps with the Western mind, or the mind that we know about, is that many of us here will understand self-hatred. I don't think, no one looked at me like I said something rude when I said self-hatred. Most of us, unfortunately, know what self-hatred means. We've either seen people we love drink or not feed themselves to death. We've probably seen patients who have, for various reasons, hated, disliked themselves so much that they harm and maybe kill themselves. And I think maybe a few people in the room will know what it's like not to like themselves, and from time to time, occasionally. That we may, as human beings, certainly it's something that I know, that capacity not to like who we are. We may, hear, I certainly hear it in my own direct therapy work with patients, that underlying kind of narrative of not good enough, of just not being up to scratch. Very frequently hear it. And I, at some level, relate to that very closely as a human being. And part of my own struggle as a human being has been to get to know that narrative a little bit better. I think the kind of the not good enough narrative, the not good enough kind of storyline that we have, I think it's quite likely, or possible at least, that not good enough narrative can turn on the high alert system, right? So back to that kind of that amygdala, the fight or flight, that stress response, because that kind of underlying not good enough narrative, well, basically, if I'm not good enough, well, then I'm going to be rejected. And if I'm going to be rejected, well, then I'm going to guard very, very cautiously against that. So I'm on high alert, sensitive to rejection, the pain of rejection. So often, I think sometimes what we see is that button, that high alert button, being switched on. There's a guy I know who's written something recently, and he talked about the concept of just not being enough. So not even not good enough, but sometimes just not being enough. It would appear the Western mind, or the minds that we know a little bit about, are often affected or beset by feelings of not good enough. We've probably kind of lumped a lot of that into and refer to that as low self-esteem. So the idea that so many of our difficulties are the result of low self-esteem, or the kind of not good enough. I think the Western mind is very used to, or very prone to, being on high alert, and we might understand or call that the idea of stress and being stressed out. So just as I said about the doctors and nurses, intuitively recognizing that, oh, I could do with some of that stress response, that stress management stuff. So we might see or understand the Western mind as one struggling with self-esteem, and then secondly with stress, with the high alert. And as you know, contemporary psychology and psychotherapy and parts of psychiatry have developed very advanced and elaborate therapies that go after or tackle the self-esteem, not good enough, or high levels of anxiety and stress. So whilst psychological interventions are relatively new, the last kind of 60 or 70 years have seen very targeted therapies at those two conditions, at those two aspects of mind. As you know, and just to recap, our interventions in healthcare, our psychological interventions in healthcare are very new, and began, with the stuff in very large psychiatric hospitals in the US, when people began to realize, that people with schizophrenia actually could change their behavior when someone withdrew or rewarded them with cigarettes. So there was a kind of actually this is not just purely biological. There's room for behavioral change here. And then everything that came out of that. So the idea of being able to intervene at a behavioral level is relatively recent, and where we began. And then, as you know, in the late 60s and 70s, the advent of cognitive behavioral therapy, and the crude explanation now, but the idea that how we kind of think about something impacts on how we experience it. So not so much the event itself, but what we do to that cognitively. So moving from kind of behavioral intervention, that can impact on behavior, desired or not, and then kind of cognition, that plays a role there along with behavior and can change or alleviate difficult emotional or behavioural problems. And then the third, Mark Williams has written about these as waves. He says that the behavioural wave, number one, the cognitive wave, number two, and that mindfulness is the third wave of psychological intervention. So 1, 2, 3. So mindfulness intervention as the third wave. He, as people know, there are two forms of clinical intervention in mindfulness. For those who don't, MBCT, mindfulness-based stress reduction, which came out of the University of Massachusetts, was targeted at people initially with chronic pain, and then had a much more broader application for people with all sorts of physical and psychological difficulties, beginning in the 70s with John Kabat-Zinn, and then much more later in the mid or late 1990s, MBCT, mindfulness-based cognitive therapy, that began with Mark Williams essentially and some others in Oxford. So they thought, let's incorporate some of this mindfulness stuff into traditional cognitive behavioral therapy. So generally, as it stands, there are two forms of intervention. They're both 8-week long. They both involve attending a class for 2.5 hours a week, coupled with about 40-minute homework 6 out of 7 days. So it's very intense. Mindfulness training is very intense. I'll say a little bit more about that later on. Mindfulness, as you probably know, is a Buddhist derived concept of practice that involves developing undistracted attention. I think it's undistracted awareness of the here and now. It's important to say that it's Buddhist derived, but I was talking to some people recently who know a lot about kind kind of Buddhism, and it's very interesting to talk to them because they were saying, oh well, actually mindfulness has really nothing to do with Buddhism at all. It's interesting because there were concerns about that, and of course there are concerns that I think are very legitimate, and as psychologists we need to be very careful about the origin. As I say, it's done through MBCT or MBSR. It's not easy. People, I often say to patients in work that it's like it's kind of boot camp mindfulness. And people need to be well enough physically and psychologically to undertake a training in mindfulness. And one of the difficulties I think with the growing popularity or kind of understanding of mindfulness is, you'd often hear people say to nurses, doctors, say to me, oh, she could do with a bit of mindfulness, like it was, something you could dispense. The mindfulness MBCT MBSR program that we talk about isn't. It's not available in a spray-on version. It requires a huge amount of work. I often say that it's like physiotherapy. It's like physiotherapy for the mind, and literally, people know that we can go to a physiotherapist and see him or her for half an hour and all makes not a lot of sense and do our exercises and then not look at the sheet until the following week. People who've been to physiotherapy may recognise that pattern. Same thing is true, it's useless. The same thing is true of mindfulness. It's about, it's a physiotherapy for the mind and requires that kind of commitment. John, people again will know, John Kabat-Zinn described mindfulness as paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. So, that's very nice, isn't it? You think, oh, that's nice. I'd like to kind of get there. That's the end product, I think. That's the end product, and requires work to get there. There's a couple of people who are doing some interesting research. One of them is Bear, written a pretty comprehensive book on mindfulness applications actually across in all sorts of areas. But she conducted factor analysis of existing mindfulness questionnaires, and she found that there were 5 kind of facets or 5 skills involved in mindfulness. I think I have them here. And this is what she said. She said that these were the 5 pieces that the desired outcome, if you like, of mindfulness training: observing our experience, describing the experience, acting with awareness, non-judgment, and non-reactivity. So a tall order. Bears she has worked on several questionnaires on mindfulness.
Sorry, Paul, what's her name?
Bear, B-E-A-E-R, 2006.
B-A-E.
Yeah. So one of the things that when talking about mindfulness, it's I often find it easier to say what mindfulness isn't, and really importantly, mindfulness is not about trying to relax. Absolutely not. Mindfulness is about turning up to the good, the bad, and the ugly of our lives. So, and often patients, a couple of weeks, they're kind of a bit restless and going, "This isn't kind of, I think I'm in the wrong class. I'm not learning to relax." Or if we're mindful, well, we should be completely relaxed all the time. That's not true. Mindfulness is not a religion. It is the application of a very small piece of Buddhist practice, but I think more globally, probably the application of something we see in a lot of world religions, and that's the promotion or the increase in awareness. But it is not a religion. Really importantly, mindfulness is not about transcending or bypassing ordinary life. A lot of people, I think, probably myself included at one point, thought mindfulness would be a way to bypass all that stuff, and it's absolutely not. And people who've done the training will know that mindfulness is about actually going right into the mess. I often say it's a little bit like, is it like the M50, so we don't have to kind of go through all the mess and the smells and the chaos of the city. There's a part of the romantic appeal of mindfulness is that, we can bypass all that. And that's actually the absolute opposite of what mindfulness is, because mindfulness is about in fact diving into life in all its glory, the good, the bad, and the ugly. And importantly, it's not about emptying the mind of thoughts. If we're looking for a time when there are no thoughts in our minds, well, then that will happen when we stop breathing, and we don't want that. So, but it's about developing, I think, actually developing an affection and a kindness towards what's happening in our minds. Not trying to stop or push them away, but develop a kindness and an affection for what's happening. Class 6 in NDCT is thoughts are not facts. Thoughts are not necessarily fact. So really promoting or encouraging the ability to watch, monitor, observe thoughts with a kindness, a sense of humour even, that might suggest they may not necessarily be true, even for a moment. I've lots more to say, but comments, questions, thoughts? Just drink some water.
When you say it's not bypassing the ordinary life, are you saying that you won't become enlightened, for example?
Enlightened. Oh no, I don't think so. I don't. I think.
This is what you were referring.
Yeah. But it's about the broadly the idea of coming home to our experience right now, and I suppose if there's any sense of well-being to be achieved or got, maybe that's where it is. Yeah. Any other?
Can I ask you one? I don't know if it's a hard question or not. But because we started with the amygdala, have we anything to suggest then the impact of mindfulness practice on the amygdala being switched on?
Yeah. Might actually, Susan, there's a couple of papers that I'm going to talk about actually. I can talk about it now. But there's been a few studies that have looked at, one in particular that looked at a large group of undergraduate students in the US somewhere, and those who had a predisposition towards mindfulness, broadly speaking. What was noticed was in an affect or feeling labelling task, their prefrontal cortex was much more active than the amygdala compared to those who didn't have the predisposition. Does that make sense? So in a task involving naming how sad happy simply was, those who had a leaning towards mindfulness, the frontal, the conductor of the mind, was more active.
Would that suggest that they were using other parts of their brain, and that's what drew them to mindfulness? Or if someone whose amygdala is in high alert, is it too far reach to say this might be a way, maybe even not to switch the immersion off, but to knock it down to a lower level?
Yeah.
Is that too big a reach, evidence-based wise?
I haven't read anything to say that, but I don't know if it is actually, Susan. A degree of a lesser degree of activity of arousal.
That would be the hope, wouldn't it?
Of arousal. Yeah.
If the awareness of what's going on suggests there is no danger now, and that you can get that message.
Yeah.
To the amygdala.
Yeah. That would be. Yeah. Maybe the hope there. Yeah.
Is there any danger, Paul, or concern in relation to mindfulness being used, maybe not in a, psychologically, as a psychological practice, that it's not can it be harmful, I suppose, if it's not done correctly in a sense?
I think it's a really important question, and I think there's a few pieces that we need to be really cognizant of. There are, in terms of an 8-week program, there are guidelines as to who that is suitable and not suitable for. Now we would maybe know some of that intuitively, but equally important is the idea that mindfulness is not for everyone, and the supervision and training of the teacher or the therapist is really important, as in the delivery, I think, of any therapy, but the supervision, training and practice. Unless I would go as far as to say that unless you're engaged in a mindfulness practice at a personal level, you shouldn't be teaching it. Full stop. You can't, you can't swim unless you're a swimmer. You can teach swimming unless you're a swimmer. So that piece is very important. And anecdotally, or from my own kind of clinical experience, most of the patients that we have through the program are patients without a pronounced or diagnosable mental health difficulty. However, we would not include people in the training program who have very high or very moderate to severe levels of anxiety or depression. This is not the 8-week program that we know, the MBS or MBCT, is not, in my view, and the literature, I think, would support a lot of what I say, is not a program for people in distress. So it's not a program for crisis when things are really difficult. People need a certain degree of psychological and physical wellness in order to enter into it. Do you know, does that make a bit of sense? Yeah. So there's a real wisdom. I think we could be wise about that. And so, of course, one of the difficulties certainly that we would see in an oncology setting is that when someone is dealing with a very big crisis in their life, it's probably the worst time to change or to introduce an alternative way to deal with something, unless it's very dangerous.
Paul, how does mindfulness relate to more established psychological capacities such as optimism, efficacy, those types?
Yeah, Steve, I'm not aware of any particular research that has looked at that, to be honest. And I think part of the difficulty, part of the challenge around that is that idea of science catching up with mindfulness and some of what we already know about personality or construct or how we are. So I'm not aware, Steve, of the literature or support around that. Would you have a little thought or even a So I'd say kind of yet to come. Yeah.
I could say one thing about it. I think we've had a little bit of the tyranny of positive thinking, and certainly in the area that we're working in, not always an option to be smelling the roses,
Yeah.
I think possibly what mindfulness is bringing is the willingness to just see things as they are and accept them as they are, without having to put a spin on it.
Yeah.
So
Absolutely, Susan. I mean, and I think we've kind of chatted about it, but do you know I can never remember her name, The Smile or Die? Fascinating book.
Barbara Ehrlich.
Smile or Die. So the kind of very popular culture that's out there, and I see it clinically. I once a week at least in people who have cancer who have been told that unless they're upbeat, positive, have lots of energy and are smiling, they're going to die. I mean, it is, and we really, as psychologists, as people who need an evidence base for what they do, really have got to challenge that nonsense. Because what it does is create this huge additional burden on people as they're going through a life-threatening illness, probably one of the most difficult points in their entire lives, and they've been told to smile. Because if you're not smiling, you're letting the cancer win. I mean, it's just, it's really criminal. I feel terribly strong about it, actually. And what happens is that you've families or partners or who kind of find this kind of glass wall between themselves, because he doesn't want to say it to him, and so they're all kind of dancing around this smile or die. At the most vulnerable point in people's lives, and in a way, some of what mindfulness and more particularly, I think, self-compassion teaches us is about, as best we can, confronting that reality, the good, the bad, and the ugly, and breaking the avoidance.
I don't have the absolute details, but I think Ursula Bates has done some research on the mindfulness and cognitive approach, and presented internationally, and I think she's written on it as well. But I remember a few years ago her telling me about testing people, and I think these might have been women with cancer, who'd had cancer, and just what stays in my mind is that she said you can actually see the anxiety, the measured anxiety dropping.
Visibly you can see it over the course of 8 weeks. Yeah, with a peak in the middle. There's quite a peak in the middle, but you absolutely, Yeah? Am I go on? The benefits of mindfulness, we talked a little bit about it, but as an intervention and its efficacy are gathering some support in the literature. Various reviews, but one most recently in 2011 by Hollis and Walker. The data would suggest that mindfulness does have a significant impact, and perhaps a unique impact, on brain functioning and immunology. And there's a couple of studies that maybe are worth talking a little bit about. Not a neuropsychologist, so I read these kinds of things relatively naively. We've a study going on at the moment in the hospital with a group of people with severe psoriasis. So we've had, we've had 29 people and a control group. So we're looking at all the standard self-report, the self-report on self-compassion and mindfulness, quality of life, anxiety, depression, and a few other self-report measures. But I think importantly, we're looking at biomarkers. So we're looking at the telomere activity and length, T-cell regulators, T cell regulators. So we're looking at the telomere at the end of the chromosome, that does it. The hypothesis is that it will shorten less quickly than the control group. So the analysis is just happening this week of that, actually. So that will be very interesting to look at some of the biological markers or not of the impact of an 8-week training program. Observation of skin is also there. Mentioned the study with the undergraduate students in UCLA with those with a predisposition towards mindfulness and a greater frontal activity. One or two others. I think it's a guy called Davidson. Yeah, Davidson actually has done quite a few studies of the impact on the brain. And he did a study where employees were randomly assigned to a mindfulness mindfulness group or a wait list. large study. I think it was 100 and something of them. The meditators, interestingly, displayed a much greater increase in left side anterior activation measured by EEG than the non-meditators. The meditators also displayed a much greater increase in antibody titers to the flu vaccine. And interestingly, the magnitude of interest in left side activation predicted the magnitude of antibody titer rise to the vaccine. So where there was more left side activity, there was greater titer to the flu vaccine. In some of the oncology studies, there's a study by Specka, I think, which looked at 109 cancer patients, and she found that compared to waitlist controls, those randomly assigned to a mindfulness group experienced a 65% improvement in mood disturbance and a 31% improvement in symptoms of stress. As people will know, NBCT is now recognised by the NICE, the National Institute for Clinical Excellence in the UK. So NBCT is now recognised along with, or the same as, antidepressants to prevent relapse in people with depression. So these findings, the research, as we began with, is beginning to accumulate and catch up with the popularity of mindfulness. So apparently, now this is fairly ladybird as well. Yeah. The chromosome. So the telomere is the plastic piece. You know your shoelace. So the plastic piece in your shoelace, the end, the cap of your shoelace, that's the telomere, right? And the older we get, or the more stressed we become, the quicker they wear down. Okay. Now they wear anyway, right? But the quicker they wear down. So the hypothesis is, and this is based on a little bit of research that's been done already, the hypothesis is that the patients that have done the mindfulness intervention, the 8-week program, that their telomere will wear less quickly than those on the wait list. Does that make sense?
That's just from an 8-week, like pre and post
Yes.
service. Okay.
Yes. I'll tell you in a couple of weeks.
And assuming that the conditions are in place, like facilitators are trained, as you were suggesting, and all those things. I mean, that's all kind of basic to all the benefits that have been proven, isn't it?
Exactly. Exactly. And one of the important things about this study, and who knows, this is what we call mindfulness under the microscope. So it's unnerving at times. One of the interesting things about this study is that the patients in the group are on these things called biologics. I don't know really what they are. Third generation drugs, hugely expensive and have really bad side effects. And they manage psoriasis really well, but they have really negative side effects. And I think they're about 30 grand a year. Which is the secondary concern. The side effects are huge. So the idea is kind of going forward that we might be able to look towards kind of dose reduction. But we'll see. We could be looking at, they got worse. The telomere is kind of completely disintegrated over 8 weeks.
The 8-week courses that you mentioned are obviously very valuable and the kind of entry point for a lot of people using mindfulness. I sometimes feel that the way it's being researched hangs too much on the 8 weeks, and that at the end of the 8 weeks you might really even be beginning to understand the nature of what it is that you're seeking to have grow, if you like, within yourself. And so therefore I always feel very cautious about pre and post around the 8-week programs. And so I'm wondering, has anybody done a different form of research in terms of following a group that maintains their practice for 6 months, 8 months, a couple of years, rather than an 8-week practice?
I think that's a really, really important piece of research that needs to happen. And there are a number of smaller pieces, qualitative pieces, that have followed a number of people over a period of time, 4 or 5 years, and looked at what has happened. We've attempted to do it a couple of times, and I've had real difficulty with that for some logistical reasons. Sometimes people not wanting to come back to the hospital. Sometimes a lot of patients have died. So we've had logistical problems trying to do that. And also just in terms of, I think in terms of the potential kind of sampling bias and who's turning up and who's taking part. But I absolutely agree with you what you said, Joe, in terms of the 8-week program is literally, it's kind of the toe in the water. And of course the question, even in terms of the dermatology, the psoriasis study, will be, of course, well, in 6 months' time, it'll be any better. I mean, might all be very well after 2 months, but is that sustainable, and how do we sustain that kind of practice? Because you are looking at quite a paradigm shift in terms of how people view themselves and the world. And I don't think that happens easily, and I'm not sure how. I'd be interested to see the evidence in terms of the sustainability, and I have all sorts of questions about that. Yeah.
Because I think the danger of mindfulness becoming devalued in terms of what it does have. Because it's like I said about somebody teaching, they've got to be practicing.
Yeah.
But equally, to understand what it offers, you have to be practicing it too.
Yeah.
And I just fear it may, in fact, in another couple of years, just be seen as another fad that came and went, and that would be a great pity.
I mean, it's interesting because, and as we talk, sorry, I'm just thinking a little bit about the RCT that Mark Williams conducted in the UK that looked at people with recurrent depression, as we talk, and they were followed up, I think 9 and 12 months later, so a couple of hundred people in that study. So that provided evidence enough for the National Institute of Clinical Excellence to say, oh, actually, this is sticking. But I again, I think it's I think it's a really important question. Will I go on for a little bit? Actually, so the literature is beginning, I think, to say that mindfulness does have some sort of impact and does work a little bit. Okay, we may have confidence to say, yeah, we think it is working a little bit, but we don't know exactly what works. So if someone comes in for an 8-week mindfulness training, 2.5 hour class of 2 hours, 2.5 hours, and then they're practicing for 40 or 50 minutes a day, 6 or 7 days. There's a lot going on there. So we don't understand what is it that's working. So even if we're to look, John, particularly at the RCT in the UK, that the recurrent depression, we actually don't really know what element of it is the worst. Was it, there's lots of things going on there. And one of the guys that's done, I think, some really interesting work on this is a guy called William Coitlin, and he's in the University of Exeter. And William had this kind of a question going, okay, we know that it kind of worked, but we don't know what the variables were, or what was the key variables, what was the key components, the mechanism of change here. And he, through some of his work and a couple of other people's work, there would be some evidence to suggest that one of the most important variables for change, or mechanisms for change, is self-compassion. So, and he identified that through a very large RCT that's happening in the UK with Mark Williams, that self-compassion seemed to be one of the components that was bringing about greater change. So self-compassion, well, what on earth does that mean? Borrowed from the French, borrowed from Latin by the French and then to English, and essentially, I can't pronounce it in Latin, but essentially means to suffer with. So compassion means our ability to suffer with the other. Compassion is a response to the inevitable adversity that all human beings will face in their lives, whether it's the pain embedded in the fabric of aging, sickness or death, or the psychological and emotional afflictions that debilitate the mind. Compassion acknowledges, and I think this is very important, compassion acknowledges that not all pain can be fixed or solved, but all suffering is made more approachable in the landscape of compassion. That's Coykin there, who's involved with a lot of the self-compassion study end of things. So something about compassion providing us with the wherewithal to recognise that not all pain can be fixed or solved or made better, but can be made more acceptable in the landscape of compassion. This is clinically or anecdotally, this is something that I've observed has been very important for people living with a limiting, life-threatening illness, because very often it's about making the psychological, emotional, cognitive journey towards realising, well, actually this can't be fixed and may not necessarily go away. How do I live with? How can I live with that? Paul Gilbert, if you're interested in this, Paul Gilbert is a psychologist in the UK, and I can't remember where he is, but where is he? And Paul has written quite a lot about compassion, and he understands compassion as an evolved psychological capacity on the part of the human being, that's part of the human being's caregiving system. He says compassion increases our ability to care for our young, and is in that sense hardwired. He said on occasion that he understands, or his hypothesis is, that the human brain is formed to respond to love and affection. So he says, you know, when the child the infant is responded to often enough, you know, 60-40, 60% of the time maybe, getting it right. When the infant is responded to often enough, that the brain is formed to respond, that says, when I'm in distress, someone responds, someone loves me, someone comes to help. And Gilbert says that the brain is structured and formed in a way to respond to love. Paul Gilbert defines compassion very, very broadly and includes dimensions of care such as soothing, sympathy, empathy and non-judgment. Implicit in his understanding is a theory that integrates the biological underpinnings of human behaviour, evolution and human attachment. So he links his theory, his theory to the attachment theory that most people will be familiar with. Sorry, I've gone on there a bit. The origin of self-compassion is Eastern. Okay, so it began in the East. There is, however, notable overlap with Western psychology and philosophy. So, as a concept, yeah. But I think when we begin to look at some of our own field in psychology and in philosophy, we begin to see that there's quite an overlap. Interestingly, the word, the Tibetan translation for compassion, it's Tswae, I don't know how to pronounce it. And it is the same word for compassion for self and others. So it doesn't distinguish. The Tibetan word for compassion doesn't distinguish between compassion for myself and compassion for someone else. So it sees it as the same thing. Interesting. So there's an overlap, right, between the Eastern understanding of self-compassion and what we've done in the West. Socrates and Aristotle introduced the construct of eudaimonia, I think it's pronounced. And this was the human endeavour towards virtue and self-realisation. And humanistic psychologists, much more later, such as Maslow, Erickson and Ellis, resonate with much of the Eastern tradition. Maslow argued that emotional maturity was about fostering a non-judgmental, forgiving, loving acceptance of oneself and others. And Rogers, having written extensively about unconditional positive regard, talked a lot about the unconditional positive regard towards oneself. And Ellis referred to the unconditional self-acceptance as key. In fact, Ellis understood the key to psychological well-being was about developing an attitude of tolerance for the uncertainties in life and acknowledging and forgiving one's limitations. So there's overlap. One of the leading researchers in the field is a woman called Kirsten Neff, N-E-F-F, of self-compassion. And she says that self-compassion is made up of three things. The first being self-kindness versus self-judgment. So self-compassion involves self-kindness. So extending kindness and understanding to oneself rather than harsh judgment and criticism. She says number two, self-compassion involves common humanity versus isolation. So the ability to see one's experience as part of the larger human predicament rather than seeing it as something separate or something that I am experiencing on my own. And I think importantly, number three, she sees mindfulness actually as an aspect of self-compassion. So mindfulness not as something that stands on its own, but mindfulness as under the umbrella of self-compassion, as a component of self-compassion. And I'll just say a little bit of why I think that's really important. So in this, mindfulness is about holding one's thoughts and feelings in balanced awareness rather than over-identification. So over-identification with our own emotional, psychological responses versus the self-compassionate response, which is one of mindfulness. I think the important piece there, when Neff talks about self-compassion and mindfulness as part of that, is the mindfulness promotes awareness, and sometimes too much awareness without self-compassion, I don't know if it's a good idea. Does that make a bit of sense? So it's kind of like the self-compassion component is terribly important when we get closer to the good, the bad and the ugly of our lives. The idea, basically, that idea that, humankind, we cannot bear. T.S. Eliot said that humankind cannot bear too much reality. We can't. So we've got to be careful, I think, about mindfulness then, because it does expose us to certain realities, internal and external. Mindfulness is, self-compassion, I should say, is not something nice. It's not something relaxing, and it certainly isn't a quick fix for the Western mind. Nor is it a Pollyanna-ish positive thinking, the mind over mood. I more recently really understand self-compassion as a very radical shift in how we relate to ourselves, a very radical shift of that paradigm. That self-relationship that we have, that very radical shift in terms of how we relate to our very selves. Too much awareness in the absence of self-compassion, I think, is questionable. The practice and supervision of the mindfulness teacher is paramount here. In ensuring good quality and ethical care and delivery. Self-compassion is essentially, I think, in a nutshell, it's about befriending what we've rejected in our lives. It's about approaching the deeply buried shame, often our camouflaged self-loathing or disliking, and those recurrent thoughts of inferiority that we talked about a little bit earlier on, that often are responsible for the always-on switch, for the high alert. Self-compassion is about befriending some of those feelings that are likely to contribute to that. Self-compassion offers healing, and John Kabat-Zinn describes healing as coming to terms with things as they are. So not about changing or getting better or making good, but healing as coming to terms with things as they are, right now in this moment. We come to terms with things as they are by softening our fear, our resistance and our avoidance, by opening the heart to the way things are in this moment right now, the good, the bad and the ugly. I had kind of planned to talk a little bit about self-compassion and versus self-esteem, but I don't have time to do that because it's 6:30. So I might leave that for now. I think to kind of move towards a conclusion, and we could, there's some time for questions and answers if that's okay. Mindfulness, broadly, I think offers an alternative to validating unhelpful thinking. It offers a different way to relate to thinking altogether. In class 6 or 7, we talk about mindfulness as providing a different place to stand. It provides a different place to stand. Inherently, self-compassion represents a balanced concern for oneself and for others, wherein self-compassion is the antidote to separating and isolating oneself from our loved ones and indeed from the rest of humanity. The softening of feelings, feeling cut off from others or feeling shame, and that I alone suffer inadequacies and limitations and failings. Self-compassion is the antidote to over-identification with emotions or the avoidance of emotions. It's my contention that self-compassion allows us to be fully present to the most important parts of our lives. I think, and we'll see probably in many years, I maybe won't see that, but we'll see if this is true. We'll see when our research catches up with the human condition, with mindfulness as an intervention. Maybe we'll see. But my experience and feeling, and I think about the people that I mentioned to begin with. I think about her name is Rose, the elderly lady, 88, who said to me that she wished she hadn't worried so much. And I think about the other gentleman in his early 40s who has died also, about having the most difficult, the hardest, he said, Paul, the hardest thing is I had a great life, but I just wasn't there for it. And I don't think that mindfulness, and I certainly don't think that self-compassion is a wonder drug, but I certainly think that self-compassion can contribute or help us to be there for the lives that we have. The good, the bad and the ugly, we can't really choose. We either choose to be there or not. There's a poem that I'd like to, most people will probably have heard it, but I'd like to read it. It's called, to finish with, it's called An Autobiography in 5 chapters. Number 1. I walk down the street. There's a deep hole in the sidewalk. I fall in. I'm lost. I'm helpless. It isn't my fault. It takes forever to find a way out. Chapter 2. I walk down the same street. There's a deep hole in the sidewalk. I pretend I don't see it. I fall in again. I can't believe I'm in the same place, but it isn't my fault. It still takes a long time to get out. Chapter 3. I walk down the same street. There's a deep hole in the sidewalk. I see that it's there, but I still fall in. It's a habit. My eyes are open. I know where I am. It is my fault. I get out immediately. Chapter 4. I walk down the same street. There's a deep hole in the sidewalk. I walk around it. Chapter 5. I walk down a different street. So, I think that self-compassion for people like people like us, self-compassion perhaps allows us to walk down a different street, not to avoid, but to walk down a different street, with ourselves. Yeah. So I'm going to leave it there because I can't say anything else. Yeah, I will, and then I won't say anything else. The idea that the easiest way to ease our suffering is to experience it fully. It's exactly what we're told not to do, isn't it? Not to avoid it, keep it away. So the easiest way to do that is to experience it fully. Mark Williams says somewhere in some of the writing he's done, he says, I recognise the irony in this, but he says, the easiest way to relax is stop wishing things were different. So that one when you get to like Christmas Day, Christmas dinner, they're all around you, and you're kind of going, so we enter in, we ease our suffering by experiencing it fully. So, a couple of minutes, because it's just, what time did we finish at, Susan? Kind of now?
We'll be at the 7th,
A couple of minutes.
Yeah. Might get a little bit of feedback on that.
Generally, yeah. So, yeah. Peter.
Thanks for that, Paul. It's superb. Two things. In the world of quality control, there's a writer called W.M. Deming, and he would say there are very important variables that we need to work with that we can never measure, but we still have to work with them. And I think this strikes me as a
nice to hear.
That, and as psychologists in the struggle for evidence-based and our caution around good practice, which is where we are now, I think sort of consumed. That's the first thing to say. The second thing that we psychologists hate with a vengeance, which I'm about to do, which is self-disclosure. And that's really awfully cringe-making in an evidence-based thing. But I had a year of cancer, and in the course of that year, my daily morning reflection that drove me in and out of the madness of the treatment and pain and suffering, that the piece that carried me through all of that was that daily morning reflection. And it went on for over a year and a half. And without that, I don't think I would have had the equanimity. And the observation of people who were looking at me was that I was carrying this off very well, and I was not as bad. I mean, it was quite serious at the time. But I'm absolutely convinced, that morning reflection, that sitting in that space, and all the emotional distress that surfaced as a result of that vulnerability was hugely important part of my maintenance in that treatment. And I have no doubt about it. And while I like the idea that we would wait for, that science will catch up on practice, but really, we mustn't wait till science catches up on practice.
Yeah, because we wouldn't do anything. We wouldn't do anything. So we've got to be wise about where we go.
But you can't do research until you try something.
Exactly. And the feeling is, that if we do that with it's about our intention, and if we do that with goodwill and with love and as much wisdom as we can muster for the people who sit in front of us and for ourselves. DJ, I'd like to thank you for both of those contributions, and most importantly for your own disclosure. Thanks. So, don't know. I mean, I also be happy to, happy to leave it there.
I think there's thanks very much, Paul, by the way, it was great. I think there's a struggle, I suppose, I'm just thinking at a societal level in relation to us. You mentioned the Western mind a bit, and us being in a Western society, and I was thinking about myself, that the grasping bit, I a bit of an understanding of Buddhist psychology, not limited enough, but that whole idea of grasping or whatever. So the whole idea of us being in a consumeristic society, and I was thinking about the Euros, and you see the advertising for the new Sony Bravia, and you're thinking, geez, I love that. But then you say to yourself, that's just more of the same, and it's hard in the society that we live in to stop, you know what I mean, and stop the grasping.
Absolutely. And I don't know, I think some of that is about that kind of, it's an extension of the doing. That when I acquire, I'll be okay, or when I get it. And I mean, I've done it, we all do it. I've engaged in all sorts of acquisitions in my life. They haven't brought me happiness. Now, that's not to say, I think, it's not to say that it's very important that we reach our potential. So it's not about becoming detached from all of that, because this is where we live. But some of that desire, the attachment to that, is the belief that, I think, if I had that, then I'd be, then I'd be okay. And it gets transferred. And importantly, I think, we can even get attached. So the idea of non-attachment, we can get attached to very fixed stories of ourselves, a very fixed belief about who I am, good or bad. Or I can get very attached to maybe strong negative emotions, or I can get very attached to very positive emotions. I remember working with this woman, and he said, quite legitimately, that she didn't do stress. Wow, that's quite remarkable. The tendency in some of this, but there's a tendency in some of that to kind of get very attached to the M50, get very attached to avoiding conflict, opposition in work, things we have to face and go through. And we always say, and it's come up time and time again, that there's sometimes a perception that mindfulness is kind of related to a bit of kind of passivity. It's all about just kind of accepting it. Absolutely not. Absolutely not. It's about turning up to suffering and then making wise decisions. But first step is turning up to what's happening. Not about being passive at all. In fact, it's the opposite. But first step is turning up to what's happening. Does that make a bit of sense? Yeah. It's not.
And Paul, that's also, I think, so contrary to the current culture of, for example, medication around a variety of psychological distress, and the point that you made, the happiness trap, which is around potentially.
Even after a fortnight, we can, we can avoid that. Well, sometimes it's necessary, but it's the coming close to, it's the turning up to our lives, the good, the bad, and the ugly. But I do think we don't have if we decide to turn up to our lives, we don't have a choice, and we can't select. We're only turning up to the good, or the bad, the ugly. We dive in and experience it all. But it's again the Dalai Lama who says that it's not what happens to us that causes, and several other people have said variations of it, but it's not what happens to us that causes us pain, it's our resistance that causes the suffering, it's our resistance to what's happening.
The good old Buddha story about the woman doing her training and going to the teacher and saying, the guy down in the market is really bothering me and I can't stay very zen about it. I just wanted to hit him with an umbrella and I know that's desperate and it's all wrong. And the man says, no, that's fine, you just have to go back the next day, but if you hit him with the umbrella, make sure you do it mindfully. So what are you telling us, that psychologists, lost and found contemporary psychologists?
So, I think it maybe echoes a little bit what Peter was saying, in that this is a relatively new frontier. third wave of intervention. So it's relatively new, and it's not something that we can do as a technique, unlike other interventions that we've been well trained to deliver, maybe. So it's not something we can do as a technique, and inherently we kind of need to get lost in it, and then find something else, But it's about, getting lost and then finding that we've somewhere else to stand, some other street to walk down, maybe. So, thanks very much, everyone. Your attention, much appreciated. We have sent around a few some questionnaires, evaluation forms. We'd love if you could take a few minutes just to fill them out, because we're very serious in terms of what you might like to do in the future, and your feedback would help. And as you're doing that, if there's anything people would like to say, even verbally, in terms of what worked or what didn't work, or what they'd like to see, or it'd be very nice to hear that, I think, Susan, in terms of planning. Yeah. Good. So if there was anything.
If you can just leave them on their seats, so if you're ready, I'll pick them up. And anything you want to take off the table, help yourself.
So thanks very much, Gareth.
Well, thank you.